This series is intended to empower our members to the best ways of doing evidence-based medicine. It's a much misunderstood concept even among doctors. So let us learn to choose the right article and to blend it with the most authentic evidence, both our own and those of our experts, to churn out our own customized brand of evidence-based practice. So this time, our theme is on glaucoma. Each module will be focusing on a particular theme and a particular subspecialty. The learning module will pivot around a very common clinical question that all of us usually face in our clinical practice. And then our research expert will give us tips to how to gauge whether a particular study is relevant to our socio regional realities. And then our clinical experts will share their immense wealth of experience on the same subject. Once the webinar is over, a self-assessment come competitive quiz becomes live on the KSOS website, which you can all take. It will be live for 2 weeks, and exciting prizes await the winners. And lastly, each module comes to an end with a KGO flashcard with the key points from the webinar hitting your inbox a few days after this webinar gets over. So it's actually a 5-step learning process, and this will be repeated every month. These are once in a month modules on different subspecialties, and it will run from March to October. So with this introduction, now let me pass on to my pleasant responsibility of welcoming our dignitaries here. Let me first welcome our beloved KSOS President, Dr. Mahesh. He's here to inaugurate this launch of this webinar series. Welcome, Dr. Mahesh. Next, let me welcome our Honorary General Secretary, Dr. Biju John, who is here to support and felicitate this event. A very warm welcome to you, Dr. Biju John. Next, may I welcome the man who is actually leading the show, Dr. Praveen Nirmalan. He's a research mentor. He is actually a multidisciplinary researcher and mentor with expertise far spilling out of ophthalmology, but he's also a veterinary surgeon, and I'm sure that his expertise will have a special ophthalmic flavor. Dr. Praveen is no stranger to us because he has mentored us all maybe 2 to 3 years back. If you remember, we had a reviewer course, a basic course on reviewership by Dr. Praveen Nirmalan during that COVID era when Dr. Sudha was the editor-in-chief. So he's here with us today, and he will be leading us through the research part of this program, through all the episodes. Now, let me next welcome we are really honored to have with us Dr. Satyan. He needs no introduction. He's the president of the Glaucoma Society of India and a key opinion leader in glaucoma internationally and nationally. So I welcome you, sir, to this meeting and look forward to learning from you. And for us Trishurians, you're very special because we share a rapport of references for our patients. Our patients keep coming and going between you and us. So thank you so much for being here with us today, and a warm welcome to you. And next, it's my yes, sir. Next, it's my really great pleasure to have Dr. Bindu with us, not only on this forum, but with me in KGO as the section editor. So she has been with me in all the glaucoma-related activities of KGO that has been happening, and even the coming issue is a themed issue on glaucoma. So she has been there with me in the planning of all these events, including this one. I thank Bindu and welcome her very warmly to this event as a clinical expert. So with that, I think I can now pass on to our next agenda of inauguration. I welcome Dr. Mahesh to inaugurate this program.
Thank you, Dr. Latika. KSOS had been very active in promoting academics in the national scenario. In fact, just 1 hour back, I got a mail from AOS saying that KSOS has got the Best State Society Award for the category 100 to 1,000 to 1,500. There's the different categories based on the numbers. So we are bagging this award for the third consecutive time, thanks to the work by our last year's office bearers, including Dr. Thomas Cherian and And in fact, previously also we have previous journal editors have done journal clubs which were quite popular during that time. And even AOS had taken some of the points from our KSOS scientific activities which they are doing in national level. So I am very happy to have this start this program under the leadership of Dr. Latika. There are two types of ophthalmologists. One academic, that means in working in medical colleges and other places where they have to teach the students, where they will go through all these articles and dissect out the pros and cons. But there is a big group who are practicing ophthalmologists who don't read all these things regularly. So these programs are for them, and the pluses and minuses of the study will be highlighted on a research background, and its implications in clinical practice will be highlighted. It's a fantastic initiative. I officially inaugurate the program, and I wish Dr. Latika and everyone a good program, and everyone enjoy the program. Thank you.
Thank you, sir. Now, now I invite Dr. Biju for a word of encouragement and felicitation.
Yeah, thank you, Lydia. Good evening, all. So, as Mahesh told, it is really a wonderful evening and really quite an auspicious day to start one of Lydia's new brainchilds. That is, we are having they just got the news of having bagged this Best State Society Award in our category for third time. So, quite a good day. And Lydia, of course, we all know is known for introducing such innovative programs. And this one also, I think, is going to be a big success and is going to be very useful for all the ophthalmologists, as Mahesh has already told. And I think she has selected the topics quite well, selected the faculty, and we got extremely capable faculty. And to make sure that all of us learn, it quite well and take away the points, I think after this, I think she's going to hit us with the flashcards. And if you still don't learn, then there is the quiz also. So with all these things, I think we are going to have a fantastic learning experience. So all the best to Latika and her team. Thank you.
Thank you, Dr. Biju. So I think we can now pass on to our scientific session. Let me invite Dr. Praveen Nirmalan for his for the first session. Actually, the research question that we have selected for today is primary angle closure suspect with otherwise normalized. We see a lot of such patients in our OPDs. So their vision is normal, fundus is normal, IOP is normal, but they have a shallow anterior chamber and they don't have any symptoms. So we are sometimes confused as to whether we should be advocating laser PI for this patient, or should we be observing, or should we be intervening in some other way? So that is the question we are addressing today. And as the first step in this module, that is apprise, we are going to apprise the SAP trial, which is a landmark trial, which actually looked into many aspects of this question. And it will be dissected by Dr. Praveen Nirmalan from the point of view of a practitioner, from the point of view of a practitioner trying to gauge whether I can actually rely on this article and whether I can actually take points from this article into my practice. So I invite Dr. Praveen. Over to you, sir.
Yeah. So shall I start?
Yes.
Yes. So thank you, Dr. Latika. Thank you, KGO, KSOS, and everyone here. So we'll start, and just a few things from my side. The series aims to get you to think and create your own interpretation from evidence to apply to your practice. So there are two important aspects here. One, that you have to interpret, create your interpretation, and then you have to apply that to your practice. Evidence in isolation or clinical observations in isolation are not optimal. So if we say that we have evidence from an article or from a presentation, and we say that I'm going to just apply that in isolation, it doesn't really give you optimal results. The same holds true if you have clinical observations alone without trying to balance that with evidence. So both have to work together. Statistical significance must be interpreted with clinical judgment. Just saying that a p-value is less than 0.05 does not actually mean much unless you interpret that with your clinical significance. And remember that the p-value is not the holy grail. P has many expansions, not all of which are politically correct. How will we proceed in this series? We look at some pertinent results from articles, explore aspects to consider while translating those results into practice. We won't go too much into the statistical jargon or the statistical conversations or dialogues. That's not the primary purpose of this series. So we will be seeing how do we interpret what is written in the article. Some of the findings we'll take and we'll look at how do we interpret that. We'll try to build a thinking process around it. And then how do you take that into your clinical practice? And this will not be an answer on a plate session, like a buffet where you can just pick up the answers and run with it, go back and say, that is not the whole idea of this session. And disclaimer is that I rarely believe anything that I said. The article is the 14-year outcome of angle closure prevention with laser iridotomy in the Songshan angle closure prevention study. An extended follow-up of a randomized control trial. That's the SAP trial. It's a SAP trial. So we'll be walking through the SAP trial and its 14 years outcome. This is a study that has been conducted over a period of 14 years. The first study was planned to end at 6 years. And at the end of 6 years, they found that the study was underpowered for most of the outcomes that they were looking at. And so they then decided that we will, we will continue this study till 14 years and see what happens. Now, the one thing you need to consider is a long duration like 14 years does not always mean that it translates to optimal results or the results are going to be very great. And you must factor in issues like diagnostic and interventional changes or advances that can occur in the interim period. And as those are being applied, you cannot withhold that from patients just because they are in a study. So as you start applying them, it can create some chaos in classifications and outcomes. So you need to start thinking about that part of it. If it's such a long duration of follow-up, what was the diagnostic criteria or measurement criteria used at baseline, and has that changed over the period of the study? Has there been other therapeutic advances or interventional advances that have then been applied during the course of the study? How do you factor those in with the results? RCTs, randomized clinical trials, are the reference standard for interventional studies. A study just does not become ideal just because it is an RCT. We need to assess how the RCT was done. And some of the things you look at very carefully are the randomization methods and integrity of the randomization process, the analytical strategy, the exact criteria and laws to follow, and type of RCTs and the underlying assumptions that have driven the sample size estimations and why you chose a particular type of RCT. Now, when I say type of RCT, multiple types of RCT designs. The common ones include a superiority RCT design, is a superiority trial, where you're trying to say that one intervention is superior to this control intervention that you are studying, and you set a margin. It's superior by more than 10% or more than 15%. You call that a superiority margin. You can say that you can design a non-inferiority trial, RCT, where you say that the study intervention is not inferior to the control intervention. And you set a margin for that. So you say that if it's similar, nearly similar, the outcomes are nearly similar, say within 5 to 10%, you will consider that as non-inferior. Now, the superiority margin and the non-inferiority margin are clinical judgments. So you will say that I will use this particular new intervention X if I find that the results are superior to whatever is existing now by about 15%. So you'll set the margin as it must be better than 15%. So that's a clinical judgment. Non-inferiority margin is a clinical judgment. So when you're looking at a trial, you need to look at that. And you also need to assess if that's aligning with what you would consider as good enough to apply into your practice. This particular trial was done in a single center, so you need to consider the advantages and disadvantages of a study in a single center. A single center gives you greater control on the environment, on the research environment, on the measurement factors, on the processes. But it also introduces a lot of bias in terms of a selection bias of who accesses care at the center, and the limitation of generalizing these results to a larger population that can be diverse. Very important, consider the definitions used in the study. So if you have not read the paper, I would encourage that you start reading the paper. You look at the definitions that are being used. Do you agree with these definitions from your clinical practice perspective? You're a practicing clinician, and the most important thing for you to consider is, do you agree with the definitions that are used in the study? Are those the definitions that you use in your clinical practice? So as a homework, you can find out and read the 6-year results paper, and you could look at the definitions. The 14-year paper does not give too much about the definitions part because they have already described that in the 6 years paper. You look at who is being included, you look at who is being excluded from the trial. In this particular trial, they had excluded patients with an IOP elevation of more than 15 millimeters of mercury after the darkroom prone provocative test. These are patients who are deemed to be at risk of AAC, and they were excluded. So you need to think, okay, now if I'm excluding patients who were at higher risk for developing AAC, and then I'm starting to look at the event rate of AAC, how does that impact the results that I am seeing? Because if I'm excluding those who are at high risk for a particular outcome, then naturally, instinctively, you or intuitively, you will anticipate that the outcome rate for that particular event will be lower. So does that exclusion impact the results? And is that a factor to consider when you are interpreting the results? So you consider the impact of exclusions and inclusions on the outcomes. Do they remove or add high or low risk subgroups? And can the exclusion or inclusion or subgroups alter results? So what are the implications of excluding people with a positive darkroom provocative test or having post-dilated IOP spike of more than 15 millimeters of mercury? So when we look at the results, we need to look at the AAC rates, and then we say, okay, now, would it have been higher if these people were included? Could the effects of the intervention on these people be more? When we exclude a high-risk group, are we excluding a group that might have benefited more from the intervention? So you need to think of these factors, and those are clinical judgments that you need to work. So you're working your clinical aspects as you're going through the paper. They chose one eye randomly as the interventional eye, and the other eye was chosen as a control, and that's a good way to look at it. And it works in certain situations, especially in ophthalmology, it works well because you've got two eyes. And so one eye can be the control. Now, the reason why that's a good approach is that you can have the same person, the characteristics of the same person as a control, rather than having a different person as a control. So we can have an interventional eye and the control of the other eye of the same person as a control, which can control for potential demographic and comorbid factors that reside in that particular person. You need to look at how each variable is measured. For this trial, you would then consider how was IOP measured, how was the angles measured, what were the tests that were being done. And as you're doing that, as you're reading the paper, because your primary interest is to take this information into your clinical practice, you also need to think over how do you do this in your clinical practice? Is it the same way? If it is different, what do you think might be the impact of the different methods of measurement? For example, if the measurement of IOP or gonioscopy is different in the paper from what you do in your clinical practice, then how do you apply those results to your clinical practice? That's something that you need to consider. The primary outcome in this study was the risk of PAC occurrence, consisting of following 3 study endpoints: an IOP of more than 24 millimeter of mercury, confirmed by a recheck on another day within 1 week. So you consider this carefully. An IOP of more than 24 millimeter mercury, is that all right as a endpoint criteria? Is the confirmation all right? A recheck and another day within 1 week, is the duration all right? Do we need to have it more than 1 week? Could it be less than 1 week? Clinically, what do you think is appropriate? So for each point, I'm trying to bring you back to what you would think clinically. And what I'm trying to highlight here is that don't take a research paper results in isolation without aligning it with clinical practice, without aligning with your clinical judgment. That would not be an optimal way to take the results or assimilate the results into your practice. PAS of 1 clock hour or more in either quadrant or AAC. So AAC is one of the study endpoints. And we previously saw that exclusions had considered people who are at high risk for AAC. So you need to think, why would they have possibly excluded those at high risk for AAC? If they were included, what would the results be? Is it all right to exclude them when I'm considering an intervention with a primary endpoint of AAC? So I'm saying that I want to stop progression to AAC. So if I exclude people who are at high risk for AAC, how does that impact the results, right? So what you must look at is balancing possible differences in measurement from your clinical practice and how can you align this. Statistical methods. Well, some of you might faint as you hear stats. Some of you might salivate. Some of you might pretend to be excited while questioning or cursing my ancestry for bringing stats in now. But what I recommend is that as you start reading, keep the tests aside, the test names and all the jargon aside, and just check if what your eyes are telling you aligns with your clinical judgment. So just eyeball the results. Forget what test they use and the whole description. All that is important. But as you just start looking at the results, start looking at a table, just saying, okay, these are the numbers. How do they match with what I see in my practice? Do I see that they are nearly similar? Do I see that they're very different? How do I just look at that? Leave the p-values aside, leave the test names aside, and just look at those numbers and those proportions and the means and all those things that are there, and just eyeball and form an intuitive conclusion first. That's the first step. As we go further down the series, we'll start looking at some of the basic stats also. But to start with, let's just look at the numbers and proportions and just eyeball them. Some of the results, 83% of the study participants were women. What's your clinical profile like? So you would think, okay, in my practice, if I'm looking at PAC suspects as the inclusion, what proportion of them are women? So you start thinking about your practice. If you want to apply results to your practice, I presume that you are concerned about your practice, you are seeing a reasonable number of patients, and you are also thinking about the patients that you are seeing, right? So you start thinking about and say, okay, what proportion of women do I see? Do I see more women with PACS in my clinical practice, or is it almost equal with men? How does it work? They managed to complete the study in 499 eyes. They had about 899 eyes to start with, and they completed in 499 eyes. That's 56.13%, and 501 eyes of the 889 eyes in the control group. So about 56% of the people in the baseline, they managed to follow them up to 14 years and then complete the study. So there's a more than 40% lost to follow-up. So now you think, okay, now, is that a factor to consider? Usually we say that loss to follow-up must be minimal, but when we are doing a study for a longer duration, we must understand that a large loss to follow-up will occur, especially when you're doing a study in a demographic that's got an older age. Due to multiple reasons, there will be a larger loss to follow-up. So you don't judge a study just because there's a large loss to follow up, you look to interpret that. So, okay, if there's a large loss to follow up, what does that mean? How do I still make sense of the results with the patients that are still remaining in the study? So we look at who was lost to follow-up, and we see that patients who declined follow-up or were lost to follow-up were significantly older and at higher IOP at baseline. So you think, okay, but these patients at a higher risk for the progression or the primary endpoints to occur. So if they were at a loss, if they were lost to follow-up, would that impact on the weights of the primary endpoints that I am seeing? So when I'm looking at the primary endpoint rates, I'm going to think, okay, if I had everyone following up and they were at a higher risk, then probably the primary endpoint rates were higher. Can this impact on the reported effectiveness of the intervention? Right? So you need to start thinking about how you will factor that in, how you will think over that as you're looking at the results. The mean age at entry was 59.3 years. So consider the effect of cataract surgery on outcome measures, especially in our context of 60 years, a lot of cataract there. So let's say a 14 years baseline, 70, 74 years. You're expecting a lot of cataract surgery to have occurred in the interim. How would that impact on the results or the endpoints that we are measuring or that they measured as part of the trial? So you need to consider that. So you need to think, okay, this particular study was in China where the rates of cataract might be lower than what we see in India. So for them, that might not be too much of, may or may not be too much of a problem. For us, how does it work and how do we then interpret it? And if we do a cataract surgery, does the cataract surgery have any impact on the primary endpoints that we are measuring? And what are those impacts? So we need to start building in that clinical connection also. The 33 LPI treated eyes and 105 control eyes reached the primary endpoint. The risk of reaching the endpoint reduced by 69.9% in the LPI treated eyes. And the number needed to treat was 12.35. So you say that if you treat 12.35 people with LPI, you are able to prevent one PAC occurrence over for the progression from PACS to PAC, 1% for every 12 LPI that you are doing, 12 to 13. You're able to prevent progression to one PAC over 14 years. And as you look at that, you need to think, is that because of the endpoints that we chose? So you start thinking, okay, what are the endpoints that I might consider important in my clinical practice? What is clinically important in my context? Is this number different because of other interventions that have happened in the interim period, either in terms of a cataract surgery or things like that? So you need to start thinking over that. So how do I interpret this particular? We can take it just as an absolute statement that, well, if you treat 12 people with LPI, you can manage to prevent progression or manage to prevent one PAC occurrence in 14 years. You also consider, okay, if I do LPI for so many people, I am preventing just one occurrence. Is that good? Is that all right? Is that more? Is that less? Clinically, what do you feel? Right? So that's the way you start looking at this number. So you can see that in this particular session, I'm going to just prime you on to how do you start looking at these things and how do you think around it rather than taking those numbers or those proportions or means or whatever is presented there just at their face value. Right? So you start building a process of thinking around it and thinking around it, aligning that with your clinical practice. Thinking around that should not be in isolation or just as a statistical or a mathematical exercise. Thinking around that aligned with your clinical practice and your clinical observation and your clinical judgment. They said LPI works primarily by reducing the development of PIS. And you can see that in the control in the LPI group, there was 3.62 development of PIS. In the control group, it's 12.68. In the article, they also say that in LPA-treated eyes, a proportion of PAS of 2 clock hours or more was slightly lower than in control eyes. And look at the percentages there, proportions, 14.3% versus 28.6. So in the LPI, PAS more than 2 clock hours was 14.3%. In the controls eyes, it is 28.6%. But they say the p-value is 0.33. So it's not statistically significant. Is it clinically significant? A 14.3% in the LPIA and a 28.6% in the control. Is that difference clinically significant? So you bring in your clinical judgment there. A point to consider here is that it is not necessary that you discard a finding or a result just because it is not statistically significant, if it is clinically significant for you. It is also not necessary that you accept a finding, a result, a statistically significant result, if you feel that that is not a clinically significant difference. Right? We'll see that also. So IOP was increased moderately after PAS formation, 15.75 versus 16.42. Now the P is 0.02. So it's statistically significant. But 15.75, 16.42 in the context of IOP measurement, is that clinically significant? Is that a clinically significant difference for you in your management schedule, in your management protocols, in your management of the particular patient with PAC, PACS? Would you think that that difference is clinically significant? So it's statistically significant, but is it clinically significant? Only one LPI treated eye and 5 control eyes showed AAC. So it brings up the question, so what are we averting? And is that worth the effort from a broader perspective? AAC is one of the primary endpoints, and we are looking to avert AAC. And we are seeing that the event rate of AAC is 5 in 14 years, right? 5 of the control eyes and 1 in the LPI treated eyes. And it's not difference between, it's not very much different between the treated eyes, LPI treated eyes, and the control eyes. So what are we averting, and is it worth the effort of doing LPI? Now, as you're doing that, you come back to the point, okay, AAC is low in the control eyes, but then I had excluded people who are at high risk for AAC. Would that subgroup that I excluded actually benefited from LPI? I can't answer that now. But did I exclude them because they would have no benefit from LPI and they need something else? Right? So that's the part that you now bring in as part of your clinical judgment to see whether how do I interpret this particular result. At face value, I can say, well, there is no statistical difference and it's very low. Right? As I think over it, I can say, well, is it because I had a problem with my diagnostic definition? How did I define AAC? How did I define my inclusions? How did I define my exclusions? Is it a problem there? Is it a problem with the way I actually measured IOP? They used Goldman applanation and then a tone up and for the darkroom test. Is it a problem with the way that I had used my angle measurements, gonioscopy? Is it a problem with the other tests that I have done to arrive at my test? So you start looking back at all the way everything was measured and you say, well, does that process by itself contribute to the fact that I'm seeing a low event rate? In my practice, what do I do? Do I do something differently? Now, if I'm doing something differently, what do I think would be my event rate for this particular AAC? What is my event rate in my practice? Well, maybe you're not documented, but you have a sort of an idea. Hopefully, you would have sort of an idea about what your practice rates are. So you start thinking over that. So you start linking what you're reading with what you're actually seeing in your practice. At the 14-year visit, LPI treated eyes showed larger total angle width, 7.63 versus 2.04. LACD, limbal AC depth, 29.97, 14.91. Then the control eyes. That's statistically significant. Do you think the difference is clinically significant also? So the LPI is showing a change, or they're showing that there's a greater angle width and angle depth. One thing they could have done is they could have looked at the changes rather than comparing the changes only with the control eye. They could have also looked at the changes pre and post LPI. So does LPI alter the total angle width and the CACD and the central angle anterior chamber depth and the limbal anterior chamber depth? Does any change happen there? Check if they have done that or not. Some things you go and read. Check if they have done that or not. Okay, that's a homework for you. They also found that statistical differences were there in the IOP and nucleus cataract degrees. And they said that this was slightly higher in LPI treated eyes. They say it's slightly higher, but the statistical significance is quite high. P is less than 0.001 or highly statistically significant. So now you think over that is clinically significant. So LPI treated eyes have a slightly higher IOP. They have a slightly higher nuclear cataract. Given that we have a high background risk of cataract, that would translate into a surgery, most probably. And given that we are comfortable intervening earlier with cataracts now, so it's more likely than not that they might translate to a surgery. So how would that surgery then impact on the other factors or the other primary endpoints that they have as part of this study? So consider that also. Just to conclude the results to a certain extent, the multivariable model, they said that an increase in IOP, LACD and CACD were associated significantly with the increased risk of PAC occurrence over 14 years. So IOP, an increase in IOP per 1 millimeter mercury higher, the hazard ratio was 1.12. So it increases the risk of PAC occurrence. LACD, as the depth increases, every 10% increase in the depth, the risk reduces. CACD, every 1 millimeter increase in the depth, the risk reduces. So just briefly what the hazard ratio is. It quantifies the relative change in the hazard of an event for 1 unit change in a predictor variable with hazard ratios greater than 1 indicating an increased risk and a hazard ratio less than 1 indicating a decreased risk. It represents the relative risk of an event occurring in one group compared to the other, holding other variables in the model constant. So it's adjusting for all the other variables, all the other factors, like let's say age or whatever, sex of the patient or whatever, all that is held constant and then just based on the event. It gives you the probability of an event occurring given that the event has not occurred until that point in time. We look at whether there are significant adverse events with the intervention. The 6-year paper reported that 10% of the patients reported glare unrelated to the site of iridotomy. It also reported that 2 weeks after LPA, angles remain closed in nearly 49% of patients. Does that surprise you as a clinician? What was the primary purpose of LPI? Do you anticipate that the LPI will actually open the angle? Do you anticipate that it will open the angle by how much? This is a surprising finding for you. So you're bringing your clinical acumen, your clinical observation back into the midst, and that's something that you want to consider. And it also confirmed that the current practice of placement of superior LPI locations to optimize anatomic changes after LPI. This comes from the 6-year paper. So go and try and find out the 6-year paper and read the 6-year paper also. When you're taking this into your practice, one of the things that because you're looking at LPI as an intervention, the primary thing that you're going to consider is the improvement after LPI clinically significant. As I said earlier, just because it's statistically significant does not mean that it has to be, it does not mandate that it has to be translated into clinical practice. You have to balance statistical significance with clinical significance and build an interpretation. The event rates for IOP elevation and AAC were extremely low and were not significantly different between LPI treated eyes and control eyes. So if IOP elevation and AAC are very low and they're not different between the LPA treated eyes and the control eyes. When we say here not significantly different, they're talking about statistically significant or a statistically significant difference. Consider, okay, these were the changes in IOP. These were the change in AAC event rates. Is that clinically significant? I have to do, if I do so many LPIs, this is what I'm getting in terms of averting an AAC. Is it really worth it? What are the consequences of the LPI? What are the other consequences? A higher IOP after LPA is reported, nucleus cataract after LPA is reported. So when I balance all of that, is it really worth it? Risk of acute episodes and loss of vision is low. So what should we measure as an endpoint to make it clinically meaningful? Can we use this based on all these measures that we have? Can we say that LPI produces clinically significant changes? So think over other measurement points that possibly can be done that you can look at in your clinical practice. The rate of progression of 11.81%, 14-year cumulative risk is much less compared to the 22% reported in the Vellore Eye Survey over 5 years without LPI. So you now must think, why is it different? And one reason for the difference is the way that they have defined the conditions. So the definition has made a difference. They discuss that a bit in this particular article, and they have a very interesting statement also where they say that the Vellore Eye Survey results are not reliable because there were reliability issues because they had only 82 subjects. But as you read on, you can still see that, well, you can make your interpretations around that. I would have personally preferred not to have that particular statement there, but still. So 11.81%, 22%. Now the thing you consider here is Vellore is from near where we are. So how does it work in our population? The study is in China, 11.81%, 22% was Vellore's rate of progression. So is it different? Can we take those results from China and apply here? What are the differences there? Right? Why is it different? And find out what the Chennai glaucoma study observed. That's another bit of homework. So SAP trial defined progression if either IOP was more than 24 millimeters mercury or there was development of minimum 1 clock hour of synechia, while the Vellore Eye Survey and the Chennai glaucoma study reported progression even if 1 point synechia developed in the angle. So there is a difference in the definition, which can possibly explain the difference in the rate of progression. There can also be differences in the structure of the eyes between the two populations that can also explain the rate of progression. Changes in background risk of other conditions, including cataract, possibly including microinflammatory processes in the eye. So look at all those things and consider what definition do you use in your practice? What definition was used in the study? Can I track the results from this particular study and apply it into my practice? Now, the most important thing is, what's your goal of management when you see a case of PACS? What's your goal of management? So write that down. Note it down, write it down. What is your goal of management when you see a case of PACS? And also check out what's your rate of progression from PACS, your acute episode rate in the patients that you are seeing, vision loss in PACS in your practice, associated cataracts, then surgeries in PACS patients in your practice. Now, as you do that, you get an idea. Do I need to intervene? The thought of wanting to intervene depends on your goal of management. And if you're not clear about your goal of management in a case of PACS, you're not going to be able to take any result from this and apply. You need to be very clear what's your goal of management. It's your personal clinical goal of management in a case of PACS, right? What are you worried about in a case of PACS? Are you worried about an acute episode happening? Are you worried about progression happening? Are you worried about vision loss happening? Are you worried about something else, including that your partner thinks you're going nuts just listening to glaucoma late evening? So what are you worried about? What do you hope to avert? What are your and how do you hope to avoid that? And what's your goal of management? So you need to think of that. And that applies to any research paper that you're planning to take into a clinical domain. Right? You're planning to apply it. You must be very clear about why am I wanting to, or why am I thinking about taking this particular finding or these particular results and applying it into my practice. What am I hoping to avoid? What's my goal in doing that? Consider if the intervention offers more benefits than alternates, less benefits than alternates, if it increases risk of other intervenable aspects. In this particular thing, LPI increases the persons who had LPI had a higher IOP, nuclear cataract was more, lens changes were more. So does it increase the risk of vision loss? We didn't see much in this particular state. Does it increase the risk for PAS or other inflammatory changes in the eyes, macro or micro inflammatory changes in the eyes? Are these additional interventions? So once they develop, you intervene. So are these additional interventions good or bad in the context of PAS? Which also brings us to a supplementary or a complementary ancillary question about, does lens extraction in PACS help? And if lens extraction in PACS helps, and do we need to do LPI increasing the risk of a cataract and then think of a lens extraction, or do we do a lens extraction with an LPI anyways? So those kind of clinical questions start coming to a picture. Again, I am repeating. I'm not a fan of taking research findings in isolation and saying that they have been statistically proven and there is a statistical significance and hence go and apply that. I don't think that's the right approach to do. Take the findings, look at the findings, even if they're statistically significant or not statistically significant, balance that with clinical significance. When you're balancing that with clinical significance, you must bring in your personal clinical experience into the picture. Research papers and the evidence from evidence-based medicine is not meant to discount or to say that your personal clinical experiences are subservient to the evidence that is presented in a manuscript. Right? So you must bring your personal clinical experiences into the picture. You must balance both. Right. On the other hand, you should not also just say that in my experience, I have seen this as all research is useless, bakwas, and then I'm not going to look at that. That also is not correct, because unless you're evaluating what's happening in a systematic manner, you can be biased in the interpretations that you can do. Generally, the outcomes that we tend to remember are the outcomes that are wonderfully well and the outcomes that are devastatingly poor. And those are at the outliers. In the middle, about 90%, 80 to 90% is a gray zone where people shift between mild improvements, moderate improvements, mild consequences, moderate consequences. But usually we don't tend to remember that over a period of time. What we recollect most often is the ones that have improved significantly or the ones that have not improved at all, deteriorated significantly. So there is a bias when we rely on clinical observations alone, unless we systematically study that. So balance the two. Also consider the balance between the number of cases that you must intervene versus number of eyes that progress to outcome without intervention. So if I am doing LPI, in this case, if I do LPI in 12 patients, I might avert one PAC over 14 years. Is it really worth it, other than the improvement in my bank balance? Is it really worth it to do LPI for these 12 people? Because I'm going to avert only one particular AAC, and that too over a longer period of time of 14 years. So is it really worth it? And we're starting at, the mean age was around 59 years, 59.3 years in this particular study at entry. So you're looking at 60 years above. So is it really worth it? So that's something that you need to consider. More important, is the Indian eye similar or dissimilar to the study population eye in terms of structure and risk profile? So you must, whether you like it or not, you must look at studies that have happened in Indian eyes as well, and compare the structure here, the risk of progression here, with where the study was done. And then say, well, I get a conceptual idea of the results from that particular region. If I apply that here, based on my clinical experience, this is the way I anticipate that it will progress. So we need to bring that in, right? So the question for you is, you see a PACS in your clinic. What will you do? Do you want to do a LPI? Do you want to do an observation? We have seen some results here. We have seen that the event rates are low at 14 years. For AAC, we have seen that LPA creates they said a slightly higher IOP, a slightly higher risk of nuclear cataract. They said it's clinically significant. Vision loss is not there in the control eyes. So we are not averting vision loss. We are not very significantly creating a change in the event rate of AAC, progression to PACS. Well, LPI treated eyes showed a 69.9% reduction in the progression to PACS. So now your question that you consider is the goal of my management prevention of PACS? Is the goal of my management reduction in IOP? Is the goal of my management averting AAC? What exactly is the goal of my management? The goal of my management was averting AAC, is LPI useful? If it was preventing vision loss, they're not seeing much of a difference. Is it useful? If I say it is managing IOP, LPI actually increased IOP. So is it useful? If I say, well, I want to prevent the PAC from developing the PACS from developing PAS, peripheral anterior syncope. That is my goal. Well, yes, we see a change, 69.9% reduction, and we see some change there. Again, PAS more than 2 clock hours or more, we don't see a significant difference between the control eyes and the LPA treated eyes. So what exactly are we thinking as our goal? So that's what you think of as you say that I'm taking this result and wanting to apply that into my practice. P-values, statistical significance. I think all of us love to bandy them about and talk about them and say it's less than so this and this, but they are only pointers. Don't use them as the only criteria to decide whether to implement something or not, to translate a result. They are pointers. And underlying every statistical test is a set of assumptions. And in reality, pragmatically, most of those assumptions are not going to be met. So every statistical test comes with a set of limitations. So the p-values will come with a set of limitations. So don't rely only on the p-value. It's p-value less than 0.001. So let us do it. We saw that in the IOP 15.75 versus 16.4. P-value 0.02. Clinically, do I think that that's a significant difference? So do I say I will do it? I will do it because p-value is 0.02 or not? So you need to start thinking that you need to balance that with your clinical observations, patient profile, and contacts. And it's time to wake up, time for the clinical experts to take over. My job is done. Again, as a beginning, I want you to start thinking, look at the numbers, look at the way that the numbers are flowing, start thinking about it, putting that into your clinical practice. As we move further down the series, we'll start going into slightly more depth about, I don't want this to end up as a statistical exercise. That's meaningless. So I want it to be more of an interpretative exercise that you can then think over and apply to any paper that you read that's of relevance to any clinical question that you find. So it's more about the thinking process, working around the thinking without relying only on statistical significance and without bypassing the years of clinical experience that you have built. I think that's very important to include in any interpretation that you build. So I will stop yakking now and hand over to Ritika for the moderator session.
Thank you, Dr. Praveen. Actually, you have woken all of us up, not in the meaning, in how you meant it. I mean, you have woken all of us up and given us much food for thought, jostling all our neurons. This was one of the most clinically oriented research talks that we have had in a while. Thank you so much. So now we will, actually, I have not a couple of questions, maybe 4 or 5 questions based on this app trial and based on all our discussions here. Actually, Dr. Praveen has helped me a lot with his questions. So over to our clinical experts here. So the first thing that I would like to ask you is we have a wide range of results coming in from different trials. The SAP trial is telling us that there is only 1% chance of PACS progressing on to PAC. I'm talking about now. I am talking about 72 months or a 6-year result because of the confounders that happens in a 14-year follow up. I am taking the 6-year results. So there it is just a 1% progression from PACS to PAC, whereas our own Vellore study is saying it is around 22%. So this question is to Satyan sir. In your practice, which of these would you rather, which of it to which of these would you agree rather about statistical results of the study?
First of all, sincere thanks to KSOS and to you, Dr. Latika. And of course, I'm really happy to see Dr. Praveen, my classmate, being there with all of you. So just coming to this study, the ZAP trial versus our Vellore Eye survey. The only thing is, as mentioned earlier, the natural cause of the disease could be kind of variable between the two countries or the two ethnic groups. So having said that, there are little bit of a difference between the definitions also in both the studies. So if you really, as Praveen was mentioning earlier, when they had the comments given, probably could have been a little different. But anyway, we are not going to the depth of what the comments were. It is very difficult for us to, say which one is the exact thing. There is variables, quite a good number of variables. But when you really apply that in our own clinical practice, are we really seeing that so many people are going in for a PACS to PAC? We really cannot say blindly, because how many of us really do the gonioscopy and then we see that there is absolutely no PAS, and then the patient has developed one small PAS of say 30 degrees or 1 clock hour or even 1 point PAS. So that is a clinical judgment that we need to answer.
Yes.
If we are not really answering that, and again, having said that, how many of that same patients had come back to us on our follow-up visits? And how often that we have seen that, say, for example, the patient had only PACS, patient is coming back for follow-up. And then how many times you have done a gonioscopy? And when you had only the IOP spikes, is it that only that time you have done a gonioscopy? When the previous visit, when the PAS was there, probably that time the IOP would have been normal also. So the duration of PAS also is important. Is it just development of a PAS is going to be a spike in the IOP, or is the duration of PAS being there for a couple of years or even 3 years or plus, is it going to make a change in our total IOP? Along with that, is that the lens thickness also matters in these patients that we have to consider. So it is not, there are other confounding factors that we need to consider, just not only the PAS or Vellore survey versus this, will not be able to take it up. But this helps us to have a better understanding, because this is a 14-year survey, but that was a little shorter time. But it doesn't mean that time is only going to be the answer. We have to look at all the other factors also, because I'm not going to give you a the right answer. Okay, this is the way that you need to do things. All this gives us an idea in your own practice how much you can really apply this. So one thing, you need to do the gonioscopy on follow-up visits of all these patients and identify. Both the groups had said that once the patient develops a PAS, it could be one small point of PAS, or it could be 30 degrees or 1 clock hour of PAS. That seems to be an indicator that from PACS to patient going in for a PAC. So that is one take-home message that we need to understand from this trial.
So thank you, sir. So over to Dr. Bindu now. So we have just learned that in a PACS case, it is extremely important to look beyond IOP. Whether you do LPI at baseline or not, that does not matter, but every follow-up mandates a gonioscopy as well. And whether it should be a 1 clock hour of PS or 3 clock hours of PS, we are looking at even 1 clock hour could mean an active disease. That is the clinician's take probably. So what do you think about that, Dr. Bindu? What in this trial, for example, the SAP trial said that only IOP more than 24, that is when they put it as an endpoint. And similarly, PAS of more than 3 clock hours only they put it as an endpoint. So in your practice, are you comfortable with these endpoints, or would you like to revise those endpoints? Bindu, I think you have to unmute yourself.
Yeah. So when a patient, you're suspecting a shallow chamber or a PACS, it starts with even with the slit lamp examination, you have to be more closer, whether the AC is shallow uniformly. There are other mechanisms also which you get a clue on looking at the slit lamp itself, whether it is central is more deeper or there is a push from behind, the AC is uniformly shallow, gives you another clue of the mechanism. Like the study also showed that even after PI, the angles didn't open up in more than 50% of them. So that also shows there are other mechanisms to it. So that has to be seen. And you can have subtle changes looking at the pupillary area, which rough changes are there, or see some pigments on the endothelium. All these gives you signs, and then you go and do the gonioscopy. So then you get an additional, so it all starts with slit lamp, and then you repeat the gonioscopy. So that gives you more idea of whether the PA is just, it is not the extent of PAS, but you see, yes, there are PAs developing. So that shows that it is going into a PAC. So that is important along with the other mechanisms also.
Okay. Thank you, Dr. Bindu. So it is not just about the gonioscopy or the IOP. The initial slit lamp examination is also a must. Coming back to our question of
Can I ask a question?
Yes.
Yes. So to both Satyan and Bindu, I hope you don't mind that I just say your names like that. To both Satyan and Bindu, if you mind, I can't change it now. I told it twice. So 3 times now. 3 times for good luck. Both Satyan and Bindu. Now, coming from a layperson perspective, right? As a, not layperson, but as an individual practitioner perspective. We hear the point about gonioscopy should be done. We hear the point about looking at the angles and that there are other tools to look at the angles. As an individual practitioner, as a general practitioner,
Praveen, your voice is not heard.
Yeah. You have muted yourself.
Sorry, I muted. So as a general ophthalm practitioner, if I am a general ophthalm practitioner, which I am not anyway, forgot ophthalmology. As a practitioner, do I have to check for IOP and do a gonioscopy in all patients that I see? Number 1. Number 2, whom do I consider as a PACS? Now, all these things that we are discussing occur, we are talking from the perspective of someone who is a PAC suspect.
It is PACS.
Yes, PACS. So, whom do I consider as a PACS? How do I identify someone as a PACS for me to then start moving to the next step? In my general ophthalm practice. So, what is the process that I do?
Okay, Praveen, first of all, calling the PACS is now the definitions are quite clear that 2/3 of the angle, oppositional angle, there is no cynical angle. Okay, and IOP is normal, the fundus is otherwise normal. So that is what the PACS is all about. But whether you are a general ophthalmologist or a glaucoma specialist, you need to put in your gonioscopy to understand what is PACS. We cannot keep on saying that I'm a general ophthalmologist, I will not do gonioscopy. That is no way we can take it up. Because we are moving towards the kind of an excellence in our own practice. So we better start doing the gonioscopy. It is only a matter of which gonioscopy you use. Or now the NIDEC has come up with their gonioscopic machine instrument. So if you cannot know, if you don't do your gonioscopy, you can use the machine to understand how the angles are. So there is no way that you are going to say that gonioscopy is not going to be done. So second point is definitely all of us have to measure the IOP by applanation tonometry. So these two factors you cannot neglect and try to understand, okay, I'm a general practitioner, can I do this or can I avoid that? You cannot do that. So slit lamp examination is must. And see the central ACD as well as the peripheral ACD. The convex iris configuration in the central ACD gives us a lot of importance. So that means the moment you see the convex iris configuration, you start suspecting the lens thickness. The lens thickness of anything more than 4.5 mm plays a role in the development of angle closure disease. So all of us do have today the optical biometry or even the regular biometry, the ultrasound biometry, that gives us a good idea how much is the lens thickness. So once you start seeing the central ACD is less than, say, 2.5 millimeters, and the lens thickness, the central lens thickness of more than 4.5 millimeters makes a lot of sense. So anything more than 4.5 with a central ACD of less than 2.5, then you put in your gonioscopy. Or by moment you see the slit lamp, which is the peripheral shallow chamber, central is shallow, then these are the patients you must identify that as a PSCS. In the sense, you put in the gonioscopy also. Then identify, then slowly follow it up. Now the matter of doing the PI comes as a next question. That we'll move on after Pravin's the next question when we'll move on to the relevance of PI. So first part is this.
Yes. Thank you, sir. That was very lucid. So that also sort of begs the question that in a primary, just a PACS, just by gonioscopy, if you diagnose a PACS, that is not I mean, all those patients do not need a PI at baseline. It's the other side of what Satyan sir has just said. We have to also assess the additional risk factors like the peripheral and the central anterior chamber depth as well as the lens thickness, follow up and then decide on a PI. That is what the message till now is. So I would like to ask Dr. Bindu, how frequently would you like to follow up these patients? And whether you would include other investigative modalities like ASOCT before you decide on a laser PI in these patients.
Follow-up depends upon the findings they have, especially when you are a PACS, and then you know it is a pupillary block and there are no other mechanisms like the lens thickness or the plateau errors that you get an idea from the gonioscopy. So then you can always, if the pressures are normal and the other additional risk factors come into play now, like is the other eye, did they have an attack or what? Was there a family history, or do they require a frequent dilatation for some retinal pathologies? If they are diabetic and diabetic screening is needed. Or now commonly what we see is on psychiatric drugs. There are so many drugs that can cause more shallowing. So all these factors we take into consideration before we call them for follow-up. Yes, if you have any doubt regarding the other mechanism, definitely ASOCT helps you.
Can I just intervene in this?
Yes, sir, sure, sir.
Latika and to Dr. Bindu, are you just talking about a follow-up? Say, for example, the PACS patient has come. Is that you want to say that you just follow up the patient without doing a PA? Or is it after doing the PA, how do you want to do the follow-up? Can you just refine your statement so that Bindu can precisely give? Say, for example, you have done the YAG PI. When do you want to do the follow-up? Or you have been done, or when you want to do the PI, and is that you just follow it up?
Yeah, I would like
Yeah.
to know about both these conditions. That is when you there are a group of patients where you might defer a PI because of the other things, and where you may do a PI because the other the other risk factors mentioned are there. So when is the follow-up needed for both these group of patients?
Yeah, because
PACS
that
without
carries a
any,
lot of relevance in clinical practice.
so PACS without any risk factor, and you can always follow them up for might be 6 months. But if they are older age group and you know the cataract is going to increase, then you could have a more frequent follow-up.
Okay.
Can I
Okay.
add a question?
Praveen, you want to come in? Yeah,
Yes,
sorry.
it was
You were
there.
telling.
Yeah. So the question that I have here is, when you say follow up, what exactly do you want to follow?
That is exactly I was just going
Yeah.
to, yeah.
So
The follow
I kept telling that in the talk also. So the real question is, what am I aiming to do? Or what's the goal of whatever I'm doing? And what's the goal of my follow-up? What do I want to measure? Now,
Yeah,
each
that's
of
kind
those
of
measure,
if you have really seen that what is the kind of endpoint that you're really
yes,
looking
yeah,
at.
because
we
each
see the
endpoint will have a
intraocular.
different
Follow-ups.
duration of follow-up. So what's your
Okay.
primary or most important endpoint that you're looking at? Why do you decide that as an endpoint? How do you measure that? And why do you want, and then how do you follow that up?
Yeah,
So
that
we,
is this exactly is the study
Hmm.
helping this.
So we measure the intraocular pressure and then repeat the gonioscopy. Look for if there is signs of synechia. And then that is what I think.
Yeah.
Any other additional factors?
So
Yeah.
in your practice, in
Hmm.
your clinic,
Yeah, definitely the fundus
in your
also
in
see.
your practice, how
Hmm.
do you see the progression happening? How do you see the change in IOP or the change in the angle happening to get an approximate idea? So how do you decide, okay, in my practice, I am seeing that IOP does not change much over a 6-month period. So I can call most people, unless they are showing at a very high risk, this thing, I can call most people after 6 months or something like that. So how do you see that playing out in your clinical practice? And whatever your answer is, I have no clue, so you can happily say whatever it is.
So
And
what do we?
that is the reason I felt
Hmm.
this is one of the fantastic papers. Because all of us do call the patients for follow-up. Sister will come and ask you, sir, when do I give the follow-up? Okay, you give 6 months. Okay, you give 1 year. So what is that end point that we all really want to see? Most of the time we think we are not looking at the PAC part of it. We straight away look at whether these patients are developing glaucoma as a PACG. That's main problem for us. So the relevance is the take-home message for me in this particular study is, can we all look at, say, for example, you have done a YAG peripheral iridotomy in these patients. When the patient comes back, what is that you really have to see? One, gonioscopy. Look at the amount of PAS that patient is developing or no PAS. Even if there is no PAS, is that patient really developing increase in the intraocular pressure? If so, what else could be the other reason? That is one thing. But if the PAS is there, now it is critical for us to understand that, okay, it is any moment the patient is going to have a IOP spike. So can I change my follow-up for this particular patient than those who are not developing any kind of a PAS or other additional factors? So that gives me a lot of importance. Leave out all those patients who had developed an AAC in spite of your K, then leave only one and then another group had 5. So that is the major relevance that I can look at in this particular paper. PACS to PAC, the PAS is one of the main factors. Then, of course, we can add on to the other risk factors like increase in the lens thickness can be one of the main things that we have to look at. And for that, what are the other causes? It could be the diabetes or other systemic illnesses. Could be a causal factor for those factors, how the lens thickness is increasing. That we can always keep on adding many points to that. So relevance in our clinical practice, PACS to PAC. When you are doing a YAG PA, is it really important to do a YAG PA? That is one point. If you do the YAG PA, what is that you really look at when the patient comes back to you at follow-up? When you have done the PA, when do you really ask the patient to come back for follow-up is another factor. Is that, Praveen, you want to add something, or Bindu or Latika, all of you can just add into that.
I want to actually add, but I just want to summarize our discussion still now as baseline. If a patient comes with PACS, it is not mandatory to do an LPI at the first sitting itself. You can assess the risk further, both by clinical examination and by A-scan biometry and ASOCT if necessary. If there is a risk at baseline itself, you can suggest a risk, or the risk groups that Dr. Bindu had so nicely mentioned. You can do a baseline PI there itself, or else you can ask for a follow-up at probably 6 months, depending upon your practice decision based on what you see in your practice. And then if any of these develop, either the IOP hike or the gonioscopic progression in terms of PAs, if any of it develops, then we can go in for an LPI. I think this is where our discussions are at this point of time. So I think we have a consensus on that. Am I right?
Kind of.
Yes. So, so the next question I would like to ask is that we are all talking about laser PIs. So based on this trial, they have done it in a particular manner. So because we are looking at the results of this trial, is that the way actually it is done in your practice, Satyan sir? They have put brimonidine and pilocarpine 15 minutes prior to the PI and then done a PI, for example. The commonest side effect that, or the commonest complication they had was a local hyphema at the site, and they had an increased IOP in around 1% of people, and they had even a localized corneal burn. So the commonest thing, these were the common complications, and this is how they did their PI. So is it the same in your practice also? Are these the complications you see? And is this the pre-medication sort of what you give? Or are there any other recommendations from your side?
Well, if you really look at the peripheral iridotomy, there are different kind of machines, first of all. One is our local machine, which is made by, I think all of us know, Apasami makes the laser machines. They use a different kind of technology. One uses the super Gaussian curve, the other uses a very Gaussian mode. So the technology per se is little different. I don't know what machine, I didn't really look at in detail. But I never use any preoperative medications like a brimonidine or pilocarpine. Some cases, if I feel the iris is too thick, then I use pilocarpine. Otherwise, I just use only a bright light, or I use a blue light to constrict because it acts on the IP-RGC. So once you show the blue light, the IP-RGC effectively works, and then people becomes very small. Okay, so that is one thing. It all depends upon each individual practitioner, what is that they really are comfortable with. But in routine practice, you can use 2% pilocarpine to constrict the people. It is not the constriction of the people is important. It is how much is the stretch of the iris makes all the difference. So that it becomes thinner, you can identify the crypts, and you can open up the, I mean, by doing iridotomy, it is easier. So the commonest complication when you use a super Gaussian, that is Apasami machine, definitely yes, you have the microhyphemas. That is much more common because YAG is a photo disruptor. you know that photocoagulator, argan is a photocoagulator. In case if you feel that iris is too thick, you can use a argan laser initially, make a surrounding one, then central point you use your YAG-PI. This will be helping us in the thick iris, or if you feel the patient is on anticoagulants. And if you feel there is a must that you have to do a peripheral iodotomy, you can use an argan. You can thin out. Sometimes even argan can completely open up also. Then you can do a central small dot of YAG-PI. So that will really help you. But post-operatively, if you see that management that they have done, every hour for 1 day, I don't know, because the
And
number
that
of
also,
hours they've used may be much, much higher. I don't know, because I can't comment on that. But we usually go for 4, 3, 2, 1, every 3 days for a period of 10 days. And then we just stop it. But if you really see Chinese population and in Vietnamese, they always go with the very aggressive steroid therapy and they stop it very soon also. In post-operative period, in case if you see the Vietnamese, they use it only for 10 days, total period of steroid usage or medication usage. So there are always variables, but we can always customize for our own people, and then you can just look at it. But IOP spikes are definitely much, much lesser, and then you can just stop it. But I personally don't use Diamox. The problem is we don't know how many of them they do have the cardiac problems, one. And the second thing is how many of them have a gastritis problems. And sometimes they don't even complain about the potassium depletion in elderly people. So I'm always a little scared. I usually give only a timolol, provided that all other safety measures have been taken, contraindications are seen. So I give a timolol only for the period of steroid usage.
thank you, sir. As a corollary
One
to
doubt,
that,
can I ask?
yes. Yes, sure.
After for the IOP spike, you don't use the brimonidine? No.
So,
Sir.
Bindu, what we are talking about is we are talking about the PACS. I just wanted to be very clear. So, if you are going to do many number of shots, see, for me, it is probably 1 or 2 shots, it opens up. If you are looking at making a PA of the size of your pupil, then you make multiple shots, and then probably there is an increase in the inflammation. You are rupturing the zonules, and there is a possibility of increase in the intraocular pressure. But what is the purpose of doing a PA is even a 50 microns or even 100 microns opening is sufficient enough to break the pupillary block. We are not looking at creating another pupil. So people, we need to understand how big is the PA that we need to do so we can avoid increase in the intraocular pressure spikes post lasers. So that is an important point that I think that is we are going too clinical in this because it is a more of a research paper which has been discussed. So I think we'll just try to stick on to much of this part of it. Yeah, I'm
fine, sir.
sure whether
It's
Latika wants
it's
to go more clinically or not. Because clinically,
yes, it's clinical because this is
more into
essentially for
clinical.
practitioners. Yes.
One more thing the practitioners always faces when it's a very thick iris, can we call for a repeat sitting? They don't have the facility of the organ. So rather than shooting many at a
Definitely, yes.
it will be better to do it in a repeat
Never
sitting.
feel shy of calling your patient back and then doing a repeat PA. You should never feel shy of it. But once you start feeling the iris is too thick, and if it is kind of splitting it open and you are not able to do the PA, don't try again and again. You have 2 choices, referring the patient to another surgeon where they can possibly look at doing an organ and then making a central opening with the YAG, or you have the choice of going in for a surgical PI. If you feel there is a real relevance that you want to do a PA to avoid an ASC or PAC, patient going in for a PAC, if you feel so. But doing it in a PAC, a repeat PA or in a PACG becomes even more relevant that you need to go for it. But in a PACS case, if you feel that you are going to complicate it too much, then it is better don't try it too much, unless otherwise there is a real risk factor. That's why this paper really helps us to understand, look at the controls. Not many have developed to PAC. So how much is the clinical relevance that you have from PACS to PAC? Is that PAC a dangerous condition for them where there is going to be a vision loss? The paper beautifully describes that. That is why they say doing an YAG peripheral iodotomy in every given case of PACS may not be very relevant and may not be very useful in looking at the clinical relevance part of it. Praveen, you want to jump in for moments?
No, I think I agree with that. The primary question is, it depends on the endpoint that you want. It depends on what you're hoping to achieve and what are the consequences of that. And if you're adding more trouble to the whole scenario, again, the question comes of not necessarily a macro inflammation, but a micro-inflammatory process that the PI induces within the eye, and whether that increases the risk for PAS. Just by
Absolutely, yes. Absolutely, yes. That is one thing. And if you really look at the development of cataract post PI, that also makes a difference.
yes,
Maybe good for the clinician. I don't know.
yes,
It's a
definitely.
controversial statement which we may be making it. But then that is not only that. When you make a large peripheral iodotomy, especially beyond the colorate and more closer to the angle, you rupture a large area of the zonules as well. And the more the inflammation which you create after the peripheral iodotomy, the pupil becomes smaller. That has more implications when you're doing the surgery, especially when you're not a very well-trained surgeon. You may end up with more complications. So be very cautious in doing a YAG-PI in a PACS patients. We are not contemplating on the PAC and the PACG. PACS, are you going to complicate your cases? By doing so, the trial really gives a lot of weightage. So as we have seen that there are a lot of patients who has not come back for follow-up, but it doesn't matter. But those who had come back for follow-up, what were the real clinical findings that we can take home? One, IOP spikes. Second, the PAS development. If IOP spike is still not there and you have still picked up on PAS in some of the areas, that means these patients are likely patients who are going to have IOP spikes where they need to be called up for much early follow-up than those where you want to call them later.
Thank you, sir. So just one last question on the same topic, that is, while we are at it, there are a lot of patients on anticoagulants where we need to do PIs, especially with thick irides. So is it a mandatory or is it a good idea or desirable to stop anticoagulants? Is there a guideline on that of whether we should be stopping anticoagulants because it's an elective procedure? So in centers where it is possible, is it a recommended thing that we stop or is it not necessary?
Thank you, Dr. Latika, for this very, very important and very clinical question, because I don't want to mention the doctor's name. So when the doctor did not ask for the anticoagulant usage and the doctor did the YAG-PI, patient had a total hyphema, 8-ball hyphema, and then patient had gone to the court, and then the doctor was suspended from practice. So some of you may be aware, some of you may not be aware. So when there is an absolute necessity, you do it, provided that all the precautions have been taken, the consent has been taken, explained in detail about what is possibilities that they may have the hyphemas and what is the relevance post hyphema, what is that, how you are going to treat the patient. Okay. So having said that, will you stop icosapent? How long will you stop the icosapent or warfarin or any other anticoagulants is subject a matter that you need to consult with the cardiologist. If the cardiologist says only 5 days, theoretically, stopping 5 days is not useful because we need to understand the platelet, the number of days, the replacement of the platelets. So it is not enough for you to have only 5 days. Minimum of 7 to 14 days we really require. But is that once you stop even for 14 days, once the blood is too thin and have the tendency to bleed, and we really do not know all these patients having only because of that they have a bleeding, or they have other issues associated in the liver toxicity or the liver LFTs, how the LFT is, we don't know, all these old people. So it is very important to understand, is that really a 100% indication that you have that you want to do a PI to prevent acute attack? We are looking at preventing an acute attack for these people. We are not looking at whether the patient is going to develop high spikes. IOP spikes can be managed, but is he going to develop an acute angle closure, or is the IOP is going to have a spike? IOP spikes definitely can be managed by giving a medication. Of course, we can combine the PA once it is absolutely indicated. Otherwise, I wouldn't touch unnecessarily doing a PI in all these patients. You are inviting for a trouble.
So that part is clear. That is, in a cardiac patient on aspirin, we would reserve PI for a later date if possible. But the part that is yet not clear is whether we actually need to stop aspirin for 14 days. Who takes the call? The cardiologist takes the call, or the ophthalmologist takes the call, or is there any medical legal significance for that?
Yeah, see, basically, if you just stop it for 5 days and then you do a PA, there is no difference. So that is, if you really see that in our clinical practice, when you're doing the cataract surgery, now we say that you don't really have to stop the ecosprin when you're going in for a cataract surgery, because we don't test the iris much.
So
But
we
in
can take
this
a high
case,
risk
a
consent.
photo disruptor,
Hmm.
and when you're using the super Gaussian mode in some of the machines, definitely your disruption is much higher, and the bleeding chances are definitely much higher. If the bleeding occurs when you are doing the PI, it may occur during the PI, or there is a reactionary hypema can occur within the 24 hours period.
Okay.
Praveen, you are saying something?
My only question, you answered it. My only question was, is it worth the trouble?
That is exactly I'm saying.
Is it really worth the trouble?
Bring it in a PACS.
Yes.
PACG to an extent, yes. Even the PACG, are you really looking at the relative pupillary, not RAPD, the pupillary block mechanism as a main reason? If you feel there is a pupillary block mechanism which is going to harm the patient in sooner time, you have to take the sometimes yes risk, but majority of the time it is better to avoid.
So I think our time limit has is constraining us from further discussions. So this was really a joy. It was really a personal joy also for me to be part of this discussion. It has enriched me so much, and I hope that our viewers also feel the same. Thank you so very much for being part of this, Satin sir, Dr. Bindu, and Dr. Praveen. It was really a very enriching and enjoyable experience. So before I leave this meeting, let me conclude by saying that we started with the research, the clinical question of whether to do LPI, that is a laser prophylactic LPI, in a patient with PACS with otherwise normal eyes. That was our question. So the answer now, after all these deliberations, I hope is clear. In otherwise normal eyes means no risk factors in that eye. After all the examinations, and if it is not, the patient is not falling into the risk criteria of what Dr. Bindu mentioned as frequent dilated examinations of medications, etc., then there is absolutely no mandatory need or no essentiality to do that prophylactic LPI, especially given the microinflammations that may be associated with the LPI. and it also depends on the expertise of the person who's doing the MPA also. So there are so many variables there. So you have to titrate or take into consideration all these things. And as our mentor, Dr. Praveen, was repeatedly saying, there is no study makes any sense because of just statistical significance unless your treatment goals are clear and all these inferences are aligned properly to your clinical practice. So with that message, I think we can call it a day till we meet again next month.
Thank you.
Goodbye.
Thank you so much, Dr. Latika and KSOS for this wonderful opportunity that I could learn so many things. And really want to say thanks to my best buddy, Dr. Praveen, also for joining today. Thank you so much.